Hello, everyone. Thank you for joining the question and answer session for the 2024 MIPS Overview webinar. The Centers for Medicare and Medicaid Services, or CMS, recently posted a webinar recording to provide an overview of traditional MIPS requirements for 2024 on the QPP webinar library. Following the posting of the presentation, CMS distributed listserv messages calling for interested parties to submit questions related to the topics covered in the recording. Some of the most pertinent questions received will be addressed by CMS subject matter experts today. Time permitting, after reviewing these questions, there will be an opportunity for participants to ask additional questions. Please note that a slide deck and recording of today's Q&A session will be posted to the QPP webinar library in the coming weeks. Next slide, please. This webinar is intended to be a general summary, but this is not a legal presentation. You should refer to the final regulation documents if you are looking for current policy. Next slide, please. Here's a list of topics we will cover today. As you can see, we will begin with frequently asked questions by performance category. We will then move into frequently asked questions about MIPS value pathways, or MVPs, and Medicare clinical quality measures, or Medicare CQMs. Time permitting, we will open the line for live Q&A, and we will wrap up with information on where to find help and support. Next slide, please. As noted, we have previously recorded and posted the MIPS Overview webinar to the QPP webinar library. Today's session is a follow-up Q&A based on the material covered in the recorded presentation. Please visit the QPP webinar library to see the recording, slides, and transcript of the MIPS overview webinar. We will also be posting webinar recordings specific to each of the 4 performance categories in the coming weeks. Please check the QPP listserv and webinar library for those postings. Next slide, please. We are now going to begin the frequently asked questions portion of the webinar. As noted, we previously collected and compiled a list of frequently asked questions. Today, we will review these questions by topic, and the respective subject matter experts will provide answers. If your question is not included in the presentation or answered during this session, please contact the QPP Service Center for assistance. Next slide, please. Our first topic is promoting interoperability, and Elizabeth Holland from CMS will be providing the answers to these questions. So the first question we have is, if we are reporting as a group with multiple locations, do we need to complete the Safer Guides measure for each location or just for the group?
Okay, just to clarify, this is referring to the High Priority Practices Guide of the Safety Assurance Factors for Electronic Health Record Resilience Guides. And our guidance is you would report it once per TIN, and that refers to the tax identification number. Next slide.
The next question is, can you please direct us to where we can find the 2024 measure changes and possible exclusions for the promoting interoperability performance category?
Sure. And I'm sure I'm going to say this a lot today, but in our QPP resource library, we'll have the link to it and a later slide. If you search there, you can search under 2024 and look for promoting interoperability, and there's a item that will show up called the 2024 MIPS Promoting Interoperability Measure Specifications. We have measure specifications for every measure. And so if you go to a particular measure, you will see the description of the measure, the numerator, denominator, if applicable, all the exclusions, and really lots of helpful hints for reporting that particular measure. Next slide, please.
What documentation is needed to fulfill the PDMP measure?
Okay, so also in that QPP resource library, we have a file that is called 2024 MIPS Data Validation Criteria. And under that, you would search for the promoting interoperability criteria. And so when I looked up PDMP, what's listed there is a dated report or a screenshot that shows the MIPS eligible clinician used data from certified EHR technology to conduct a query of the prescription drug monitoring program for prescription drug history for at least one patient. It's just one patient to electronically prescribe the patient a Schedule II opioid or a Schedule III or IV drug. Next slide, please.
Can you please confirm small practices do not need to submit data for the promoting interoperability performance category, and the points will be reweighted, correct? Does CMS anticipate the reweighting for small practices to change in the future?
So just to clarify, we consider small practices those practices that are made up of 15 or less clinicians. And for promoting interoperability, we do automatically reweight those practices. However, if the practice decides to submit data, that reweighting will be canceled and the data that's submitted will be scored. And in terms of changes for the future, anything we would change, we would be proposing through notice and comment rulemaking. Next slide.
What are the new CERT requirements? How do I know if my EHR meets those requirements?
So recently we updated our certified EHR technology definition to align with the Office of the National Coordinator for Health IT, or ONC's regulations. they published a regulation on January 9th, 2024. And so they've moved away from editions, and we used to have 2014 edition, 2015 edition, et cetera. But now editions are no more. Instead, we're talking about the ONC Health IT certification criteria. And all of these criteria are maintained at 45 Code of the Federal Regulations 170.315. Next slide, please.
My HIE was shut down due to a cyber attack. Can I still report the Health Information Exchange bidirectional exchange measure?
Okay, to submit the HIE bidirectional exchange measure, you need to have a minimum of 180 continuous days, because that is the length of the promoting interoperability performance category in 2024. So you will need to be able to say yes to the following 3 statements. I participated in an HIE to enable secure bidirectional exchange to occur for every patient encounter, transition, or referral, and records stored or maintained in the EHR during the performance period in accordance with applicable law and policy. Statement 2, the HIE that I participate in is capable of exchanging information across a broad network of unaffiliated exchange partners, including those using disparate EHRs and not engaging in exclusionary behavior when determining exchange partners. And statement number 3, I use the functions of CERT to support bidirectional exchange within the HIE. So if your HIE is shut down for and you don't have a continuous 180 days, you cannot report this measure for 2024. Instead, you would have to report an alternative, and the alternative for this would be reporting the support electronic referral loops by sending health information measure and the support electronic referral loops by receiving and reconciling health information measure. Next slide.
Thank you. Now we're going to go into the improvement activities performance category. So these questions are for Vidya. The first one is, can you clarify the 50% requirement for group reporting?
Hi, so when reporting the improvement activities as a group, 50% of the group must participate to meet the reporting requirements. And so what that means is that 50% of the clinicians would be required to attest to the same improvement activity for a minimum of 90 continuous days at some point during the performance year. Next question.
The next question is, where can we access the 2024 data validation criteria? Are there resources available to help us interpret the information?
Yes, so the MIPS data validation criteria can be found in the QPP resource library. The best way to find it is to search with the word validation, no filters, and you'll get the zip file for data validation criteria for each performance year. And each zip file contains a spreadsheet with details about the objective of each activity, as well as examples for ways to demonstrate completion of each improvement activity. It also clarifies the flexibilities clinicians have in implementing the activities. Next slide.
All right, and now we will move into the frequently asked questions from the cost performance category. So Ray, the first question for you is there a case minimum for the acute kidney injury requiring new inpatient dialysis measure?
Hi, yeah, so the case minimum for the acute kidney injury requiring new inpatient dialysis cost measure is 10 episodes. And so that's the same case minimum it's always had since it was added into MIPS, and this is at both the individual and group levels. And I will note that all the details and all the case minimums are listed in the summary of cost measures for all measures, which is on the QPP website.
Thank you. Next slide, please. And the next question is, I'm a solo practitioner who shares weekend calls with 2 other groups, different TIN, different NPI. Am I designated to a specific episode if I'm only covering the weekend?
Yeah, so without knowing specifics, we can't definitively say whether this clinician would or would not be attributed episodes of a measure. But I will pass it to Allie to maybe provide some more broad information about attribution of cost measures. And before I pass it to Allie, I will again plug the QPP website, which has for each cost measure, the measure information form and the measure codes list. So these 2 documents provide a lot of details and specifics for each cost measure's attribution. So Allie.
Thanks, Ray. Yes, and so I'll just provide a bit more of a generally applicable answer across all cost measures, which is that the cost measures are going to be agnostic to the days of the week. So assuming that you are a MIPS eligible clinician, you may still be attributed episodes or beneficiaries, even if you're only practicing on weekends. And you could be scored on cost measures if you meet the applicable case minimum. Now, each measure is going to have its own unique attribution methodology. So the methods that we use to attribute clinicians or groups to a given cost measure do vary. But again, whether or not you're practicing weekends, weekdays, that is not going to impact the attribution for these measures. As Ray mentioned, great resources to take a look at to find more specific information are the measure information forms and measure codes lists that are available on the QPP resource library. And then you can also always reach out to the QPP Service Center if you have additional questions about how the cost measures may apply to you.
Next slide, please. Now we'll move into the quality performance category. We're having trouble understanding how to comply with the screening for social drivers of health measure. Does CMS plan to release any additional guidance about this measure? Lisa Marie?
So this measure does not prescribe how a clinician or group should implement this measure into their workflow. This measure was designed with the flexibility to reduce burden on clinicians. So for example, this measure allows the use of any tool to screen for social drivers of health, and therefore we believe that a clinician or a group can determine what tool or process works best for their clinical flow. If choosing to report the social drivers of health measure, the clinician would meet the measure's quality action by completing a screening for all patients 18 years and older once during the performance period. Clinicians can enact any clinical workflow and screening tool combined that works best for their practice. When reviewing the numerator compliance, the patient's medical record documentation must support that the screening was performed and that all 5 elements were included. Alternatively, documentation of a review of a previously performed standardized health-related social needs screening during the performance period is also acceptable. Next slide, please.
How does CMS score a measure that doesn't have a benchmark?
So if a quality measures collection type, such as a MIPS CQM or an ECQM, doesn't have a historical benchmark, we will attempt to calculate a performance period benchmark based on data submitted for the applicable performance period. Performance period benchmarks have the same requirements as historical benchmarks, which requires all submissions of the measure to meet data completeness and case minimum requirements and have a performance rate greater than 0% or less than 100% for inverse measures. Case minimum requirements means that the measure must have 20 submissions for each measure, for the measure, and for each of those submissions, there must be at least 20 cases for a specific collection type. If a historical benchmark does not exist and we're not able to establish a performance period benchmark, then the measure will receive 0 points unless the following things apply. 1, the measure is submitted by a small practice in which they will continue to earn 3 points for the measure, or the measure is in its first or second year in the program and data completeness is met. So in the first year, that measure would receive 7 points. For the second year of the measure, it would receive 5 points. And I just want to note that administrative claims, they're excluded from these variations that I just mentioned. Next slide, please.
The next question is, how is the data completeness requirement determined?
The entire medical record set utilized by the MIPS eligible clinicians, groups, virtual groups, subgroups, or APM entities is used for identifying all denominator eligible population during a performance period for a given measure. This data set is used for the determination of data completeness thresholds and performance for each measure. Data completeness evaluates whether a numerator outcome was reported for at least 75% or more of a denominator eligible population identified for your entire data set for each measure. When reporting a quality measure, you must identify the eligible population or denominator as outlined in the measure specification. To meet the data completeness criteria, you must report performance data, which is performance met or not met, numerator exclusions, or denominator exceptions for at least 75% of the eligible population, and this is excluding denominator exclusions. The data completeness threshold has increased and is now at 75% for the 2024 performance period. Next slide, please.
And now we'll move into questions regarding MIPS value pathways. So the first question we have is, when is traditional MIPS going away and will everyone have to report under an MVP? Michelle?
A final date for sunsetting traditional MIPS has not been determined yet. However, we are tentatively working towards fully transitioning to MVPs by the year 2029 performance period, which is also the 2031 payment year. It's important to note that this transition is contingent on several factors, including proposing the sunsetting of traditional MIPS through notice and comment rulemaking. Once traditional MIPS sunsets, we do anticipate that clinicians would report MIPS utilizing MVPs or APMs. For those clinicians in the Medicare shared savings programs, ACOs would still have the option of reporting the APM performance pathway, which includes the Medicare CQMs. Next question, please.
The next question is, can you touch on the MVP participation options for multi-specialty groups beginning in 2026?
Yes, so an MVP participant may report as an individual MIPS clinician, a single specialty group, subgroup, or APM entity. However, beginning in 2026, a multi-specialty group cannot participate as a group for reporting an MVP. Rather, they will be required to form one or more subgroups to report the MVP. Next question.
The next question is, when selecting MVPs for large multi-specialty medical groups that attest via TIN for MIPS, how should we determine the best set of MVPs to use? Is only one set required for all providers under the TIN?
So if you're a large multi-specialty group, you have the option to report on the MVPs that comprehensively reflect the care provided by the clinicians in the group. We encourage the selection of MVPs that are most appropriate and applicable to the scope of care and case mix of the clinicians reporting. It would be expected that multi-specialty groups would create subgroups based upon applicability and availability of appropriate MVPs. We do recognize that not all clinicians will have an MVP focused on their scope of care and would therefore be unable to create a subgroup themselves. For example, currently the entire group can participate as a group to report the value in primary care MVP, while a subset of those clinicians can participate as a subgroup to report the advancing care for heart disease MVP. However, beginning in 2026, this same group would need to form two subgroups. One subgroup to report the value in primary care MVP, and another subgroup to report the advancing care for heart disease MVP. So clinicians can participate as individuals, subgroups, groups, APM entity, or any combination of these 4 participation options. Next slide, please.
And then finally, our last set of frequently asked questions are for Medicare CQMs. And the question is, can you discuss how we should collect and report Medicare CQMs? Sandra?
Yes, thank you. We have a helpful resource, the 2024 Medicare CQM for Shared Savings Program Accountable Care Organizations Checklist. The checklist walks ACOs through the steps they can take to prepare for and successfully complete reporting the Medicare CQM collection type. It can be found on the Quality Performance Program Resource Library webpage. In addition to the checklist, ACOs will be able to download and review a quarterly list of beneficiaries eligible for Medicare CQMs for their ACO. The list will contain beneficiaries eligible for Medicare CQM reporting, including beneficiary level age, diagnosis, encounter, and measure exclusion information. These files are cumulative year to date and are updated quarterly to reflect the most recent quarter's data. The schedule for delivery of the quarterly files is in the checklist. ACOs can use the Q1 through Q3 list to begin to collect measure data throughout the year and set up programs and processes for applying measure specifications to the patient data. The Q4 list will contain the complete list of beneficiaries who are eligible for Medicare CQM reporting for the performance year. With all the lists, ACOs will need to use their participants' clinical workflows and provider clinical data to ensure measure inclusion and exclusion criteria are captured accurately. Thank you.
Next slide, please. Thank you. So we're now going to start the live Q&A portion of the webinar. You can ask questions via the Q&A box or through the webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so that you can speak. So we have a couple of raised hands. The first one is from Debbie. Debbie, we have unmuted your line if you would like to unmute yourself. All right, Debbie, in the interest of time, we're going to go to the next raised hand. Our next question is from Dina. Dina, we have unmuted your line if you'd like to unmute yourself. You are still muted if, all right. In the interest of time, we will move on to our next question from Sydney. Sydney, we have unmuted your line if you'd like to unmute yourself.
Hello, can you hear me?
You're a little quiet. Can you speak a little louder, please?
Okay, you can hear me, right?
Yep.
Okay, thank you for taking my call. My question is regarding the clinical data and submission. They have two registry. One is the immunization, and the other is electronic case reporting. So my question is, it looks like I read the publication on these two measures, but looks like if I'm not mistaken, is that they don't say about how do you document that. So I'm kind of looking at if a CMS audit on these two measures, how am I going to provide a documentation like that? And one another related question is that if let's say the electronic health record, let's say if that system does not support, for example, say electronic case reporting, that should be enough ground to take an exclusion on that measure. Is it correct? So that's kind of a two question there. Yeah. Thank you.
Okay, so this is Elizabeth, and when I mentioned the data validation, we do have data validation criteria on our website for clinical data registry reporting. I'm sorry, for immunization and electronic case reporting, because they're both required measures. And I'm looking to see, so it's not, if there's not an exclusion for if your cert does not have the functionality. If it is a complete EHR, it must have that electronic case reporting. And this is not a new requirement. This has been a requirement for a while. So I would definitely check with your vendor to make sure they have that functionality. You can review the electronic case reporting specification sheet that I mentioned that's in the QPP resource library, and that lists the specific 3 exclusions that are available for electronic case reporting. I hope that helps.
Yes, maybe I can say a little bit is that our ACO have over 200 practices, and we have like an assortment of over 20 different EHR platforms. So, and we start looking at that, and I found out that some of them may not explicitly, because you have the healthid.gov, they have a website listing all this certified search. And so I look into that and look at some of them, they may not list that, let's say, the electronic case reporting as one of the features they support. So that's why I have this question. So maybe based on that, what I would do is let me dig deeper and see the chat with that, that the EHR vendor and see whether they actually support it or not. So yeah, thank you so much.
Okay, sounds good.
Yeah.
All right, thank you. In the interest of time, we're going to move on. We are running a little over, so we can take one more question from the line, from Holly. Holly, we have unmuted your line if you would like to unmute yourself.
Am I unmuted? Can you hear me?
Yes.
I just wanted to confirm that regarding TEFCA and QHIN for the interoperability requirement for closing the referral loop, is that an attestation with no numbers reported? So if a practice has implemented using a QHIN under TEFCA, that would count?
Yes, it is yes, no attestation.
Regardless of whether or not there have been any interactions, as long as they've implemented.
We need to read the specifications sheet for the TEFCA measure.
Mm-hmm.
Which for some reason I'm not seeing. Oh. Don't know why it's not in the resource library, but we'll need to look into that and why. Oh, there it is. There it is. So what you need to be able to do is attest that you're a signatory to the framework agreement and that you have enabled secure bidirectional exchange to occur in production for every patient encounter, transition, or referral. And the record stored and maintaining the EHR is in accordance to applicable law and policy. So as long as it's enabled, there may not be any exchanges. I think that would be really unusual because you need to have it enabled for 180 days at least.
We would hope so.
Yes. So, I mean, I think that would be unlikely, but you don't need to submit those numbers. You just have to submit a yes.
Very good. So as long as you're implemented, you're good to go.
Yep.
Thank you very much.
Sure.
All right, thank you. And then we see there's a couple more questions in the process of being answered in the chat. So in the interest of time, we will move on to our help and support section while we wait for those answers to be completed in the chat box. So next slide, please. And next slide, please. So this slide shows a list of key resources for the Quality Payment Program. At the top is the QPP website, which is where all the key information is posted. Additionally, the Participation Status tool, Explore Measures and Activities, Explore MVP pages, and more can help you navigate participation in the program. Our QPP resource library holds many resources about the program, including fact sheets, user guides, and policy resources. And the QPP webinar library contains all of our webinar materials and will include the webinar today. Moving on, the QPP Help and Support page is a great resource along with the monthly Small Practice newsletter. And finally, the QPP listserv is at the bottom of every page of the QPP website. This is an important communication tool for QPP, so make sure to sign up to hear about programmatic announcements, including availability of new resources, deadlines, and rulemaking updates. Okay, we're already on the next slide. Another great resource is the Quality Payment Program Service Center. You can contact them Monday through Friday, 8 a.m. to 8 p.m. Eastern Time. You can email them, call them, or submit a ticket online. Again, if you have a question that was not addressed on today's call, we encourage you to contact the Service Center. Next slide, please. So as we just wait a couple more moments for the questions in the chat to be wrapped up, we wanted to thank you for joining us today to ask questions and learn more about MIPS, and we look forward to speaking with you soon.